have one. They'll have several of these, but if you're working in like skilled nursing or somewhere like that, you won't have access to the ASIA scale. And they're really handy to have, so you can know what muscles to focus on and things like that. There's, yeah. There's 3 different things. Got it. Yeah, please. All right, so who here has ever known anyone or dealt with anyone that's had a spinal cord injury? Either a high level or a low level spinal cord injury. So that's what we're going to talk about today. And then when we finish with the lecture, we're going to go over to the lab. And I'm going to have you guys teach me how to use adaptive equipment. We're going to pretend like I've got a spinal cord injury, and you're going to teach me how to do a sliding board transfer, teach me how to use adaptive equipment for feeding and things like that. So we can just kind of make sure that you've got a good handle on it. Thank you very much, sir.
You need more coffee? This one, how many?
Okay, so some of this information is going to be new, but a lot of it's going to be from older chapters, even from over in 204, the first BizDis. So some of the adaptive equipment, things like that, the ADLs, things that you're going to learn. So hopefully by the time we're finished with this chapter, you should be able to describe the physiological mechanisms that cause the various types of spinal cord injuries and diseases. Explain the impacts of an incomplete versus a complete spinal cord injury. Determine the various resulting physical and psychosocial impacts. And keep that in mind as we're going over the spinal cord injuries themselves, the psychosocial impacts that most every patient's going to deal with, because the most common, normally we're dealing with teenage boys that have the majority of the spinal cord injuries, because teenage boys are just dumb, right? So they just do all this stuff, and that's usually the result is a spinal cord injury. The functional impact on the client, the community, their family, their friends, and some identify some interventions with spinal cord injured patients. So, you want to first you want to look at. I'm not going to be able to get to. How do I get to the actual notes, Cody? You don't have those pulled up, do you? Okay, never mind.
I printed out for you the next slide.
I know, but there was a. It doesn't matter. There was a YouTube link that I was going to have you guys watch, but it's okay. We'll figure it out. So we're going to review. I want you to review especially the cervical levels. The top levels are the ones that are the most debilitating. When you start getting down to the thoracic levels, you've got some upper body control. You've got trunk control and upper body movement and things like that. But the cervical levels at the top, there's 7 cervical vertebrae, and there is. Think about it as the meal times. 7, 12, and 5. You got 7 cervical vertebrae. You got 12 thoracic vertebrae. And then down here, you've got 5 lumbar. These are all fused, but you've got sacral and the coccyx, okay? Each of your thoracic vertebrae correspond with a rib. That's how you can tell which one is which. So the ones up here at the top, the C1 through the C7, those are the ones that are the most debilitating for the patient if those are fractured. Why do you think that is? Sort of. What happens with a spinal cord injury? And you have your nerves. When one of your nerves is severed, okay, up here, what happens below it? There's nothing, right? There's no communication from below that level, from that lesion and below. So if you have a C-level spinal cord injury, especially if it's a complete spinal cord injury, there's no more communication between the brain and the spinal cord, which so virtually the rest of the body is paralyzed. The lower that you go in the spinal cord injury, the more of the upper body that's preserved, okay? So let's look at some common terminology first. What is paresis? Paresis versus plegia. Paresis is weakness, okay? So think about hemiparesis or hemiplegia. If a person has hemiparesis, then they're very weak on one side of their body because hemi means one side. If they have hemiparesis, then they're most likely paralyzed. Or I'm sorry, hemiplegia, then they're most likely paralyzed on one side of their body. So there is a difference when you look at a person's diagnosis between paresis and plegia. Okay. Tetra. How many people have heard of a person being a quad? Okay. The new term is now tetra because tetra means 5, quad means 4. A quad means all 4 limbs. Okay, all 4 limbs are affected. It doesn't mean all 4 limbs are paralyzed. It means all 4 limbs are affected. But you can't have all 4 limbs affected and the trunk not be affected as well. So that's the reason that they changed quad to tetra. So now it's either tetraparesis or tetraplegia. Okay. Para means 2 or the lower half. How many people have heard of paraparesis or paraplegia? Okay, so that means 1/2. Usually the lower half is preserved. The upper half is the one that's has the issues. And then hemi is one side or the other. Okay. All right, so let's look at the ASIA scale. So ASIA stands for American Spinal Injury Association. There are different standardized assessments and classifications. It's a scale that determines the different classifications of the spinal cord injury and the neurological level that you're dealing with. It tests 72, it tests motor and sensory, and it usually is performed within about 72 hours after the injury at the trauma center, okay? They wait for about 72 hours to do this because initially the spinal cord is in shock. So it's usually 24 hours to 2 or 3 days that the spinal cord will be in shock. And if you do it before that, you're going to get a false reading. So that's why they normally wait for 72 hours. The way that ASIA levels are determined, the AIS or the ASIA is the organization. The ASI is the actual scale. Okay. So the AIS, ASI, AIS. The AIS is the actual scale. This determines the person's functional impairment as a result of the spinal cord injury. Okay. It determines how much sensation is felt by that person after like a light touch or like a pinprick on the skin or the corresponding dermatome. A dermatome is where the nerve connects to the skin. And if a person has like some sensation in a certain part of the skin, then they'll follow the dermatome line, the way that the nerve would normally go, provide some sort of a sensation, stimuli. And if the person feels that, then they mark that on the ASIA scale. As far as dermatomes and myotomes go, you do not have to know those. You don't have to memorize those. If you are going into a specialty for spinal cord injuries, which won't be for at least a year because you want to make sure that you're generalized first, then you will need to pay more attention to the dermatomes and the myotomes. But as far as for testing purposes, just know that it's a thing. You don't need to know where they are, okay? Because that's a specialty. You don't need to know specialties right now. It also looks at key muscles and the different components. And those are called myotomes. So myotomes does the same thing as a dermatome. It's just with muscles and not the skin. Okay. Derm, like dermatologist, myo is the term for muscle. So myotome is the nerve that connects to the muscle. Dermatome is the nerve that connects to the skin. Okay, it looks at the key muscles. And it looks specifically at the C5, the T1, the L2, and the S1. Okay. And there's a reason that it looks specifically at those, because those are where the plexuses are formed. And I'm not going to go into plexuses because those are way too much. But those are where the plexuses are formed, and that's the reason that we look at those key places, okay? C5, T1, L2, and S1. All right, so let's look at the incomplete versus a complete muscle. When you have a complete SCI, you want to focus on the ASIA scale A, okay? This scale has A through E on it. So you're going to focus on ASIA scale A. And then if it's incomplete, you're going to focus on B, C, D, and E. How do you determine if it's a incomplete versus a complete? Clinically, how would you determine that? Right, you're going to test dermatomes and myotomes. What's an easy way to tell if it's incomplete or complete?
No, you can tell like if the injury itself was complete or incomplete. Ask the patient.
Anal sphincter. Oh. So you digitally insert a finger into the anal sphincter, and if the sphincter closes on your finger, it's an incomplete SCI. If it does not, it's a complete SCI.
Can we do that? Can we do that?
In a specialty.
Okay,
So we don't specialize.
Normally, huh? If the anal sphincter closes around the finger, then it is an incomplete spinal cord injury. Why do you have to use a finger and not something else? You don't know?
Oh, yeah, I guess.
Because right. Who said that, Jennifer? So you could feel it.
But so if it just is like relaxed,
Right, if it's just flaccid, if it does not squeeze around the finger or there's no resistance, it's a complete spinal cord injury. I always love to throw that one in because they're like, we're not going to do that.
It's an involuntary movement.
That's an involuntary, yeah. I mean,
Not anybody.
no,
Is there a difference?
no, I'm not, no.
Is there a difference
I have had to
involuntary
dig out
movement?
impaction, so it's not really that different, but
Is there a different involuntary movement you can use?
no. Because
we have another option.
the sacrum is what controls that sphincter, and if it's a complete spinal cord injury, then it means it goes all the way down through the sacrum. So that's the only way to do it.
How far?
Oh, just at the tip.
Oh, okay.
Yeah, I mean, it's like, I don't know about,
Like your first knuckle?
oh, I wouldn't go that far. That's a good question, though. I mean, you really don't.
That was the YouTube video you didn't get.
Yeah, that was it. This is how you determine. No. Y'all can watch that stuff on your own. Nah, see, you always think about that now.
Yeah.
Do what?
I said we won't forget it. All right. I feel like I need to like tell people this, like my friends and family.
Run out and tell them. I would like rent a billboard if I were you. Be like, guess what I learned? All right. People with a complete spinal cord injury, they can't move, they can't feel anything below the level where the trauma occurred. Okay. But those with the incomplete spinal cord injury may have some sensation and they may have some movement below the level of injury. Okay. And we're going to go over some syndromes here in a minute. And then you also want to, you have to consider what's called the zone of preservation. Okay. That is a zone that's used for people that have an incomplete spinal cord injury. And they have some level of, or I'm sorry, used with a complete spinal cord injury. These people will have some level or motor or sensory intact below the level of injury and above the S5. Okay, that is very uncommon. Usually about 3 out of 100 will have some motor or some sensory preservation with a complete spinal cord injury. But just know if you're ever asked about the zone of preservation, that's what that is.
Did you say above S5?
Yes, above the S5. Okay. So if you look on page 914, these are some of your syndromes. These are incomplete spinal cord syndromes. Okay. The first one, you've got the anterior cord syndrome. This is damage to the anterior portion of the spinal cord. Okay, the posterior portion of the spinal cord is injured much easier than the anterior portion. Some of the symptoms of an anterior spinal cord include loss or decrease in pain levels, the loss of a temperature below the pain level or below the damage. Normally, they tend to progress a little quicker with anterior spinal cord syndrome because they have an intact proprioception. Okay. The next one is the central cord syndrome. Now, Most of the time when you think about a spinal cord injury, you think about the person, they may still have some movement or sensation in the upper extremities, but nothing in the lower. The central cord syndrome is opposite of that. They normally have something preserved in the bottom, but loss of function or sensory in the top. That's the only time that you will ever see someone with a spinal cord injury that has more on top than they do on the bottom. No. I have never seen it either. Well, I've seen it in like videos, but not in person. Next is your posterior cord syndrome. That's damage to the back of the spinal cord. They have good muscle power. They can feel pain and temperatures, but they have decreased muscle coordination. Sorry. This little puppy is sick. And he's done pooped everywhere. So like, can I stay home and clean this up? Yeah. All right, next will be your Brown-Séquard syndrome. That's damage to one side of the spinal cord. These people will have a loss or a decrease of muscle power with a little bit intact, and then temperature on one side and opposite of the other side. So they'll be able to feel stuff on one side of the body, but be able to move on the other side of the body. That's normally a result of like a gunshot wound or some type of trauma. Okay. And that a lot of times that's what you'll see. There's a movie. Y'all may have never seen it. Mackenzie Phillips was in it. That her husband, she had gotten a restraining order against him, and he, just kept coming and beating her up. And there was a cop that was called, and he retired. He was retiring that day, and he just stood there and watched as the man kicked her and stabbed her like 13 times, and she ended up having that syndrome. That's a true story. Yeah. And she ended up getting like millions from the city, but still she ended up with that syndrome where, and she had like a 5-year-old little boy, and she could feel stuff on one side, but she couldn't move that side. She could move the other side, but she couldn't feel anything. And that was a result of the trauma to her spinal cord. All right, then the last one is the Cotta-Equina syndrome. That is a partial to complete loss of movement and sensation below the level of the injury. That is damage to the Cotta-Equina. All right, next slide. All right, so we're going to talk now about some medical interventions. Anytime that a person has a spinal cord injury, a traumatic event, not a syndrome, but a traumatic event, they use the ABCDE algorithm of advanced trauma life support. This ensures that the person has stability of their airway, their breathing, circulation, that it minimizes, it can help minimize their disability and exposure, okay? They use cervical collars, backboards. Surgery is often done for more stabilizing of the spine, and it's always results in an ICU admission, okay? The reason that they do the ICU admission is because anybody that has a level C spinal cord injury, any level, any C level, okay, from C1 you're gone, and then C2 down you have varying disability. But they have a decreased ability to regulate their blood pressure and their heart rate. So ICU is normally, they usually admit to the ICU so they can avoid hypoxia. Does everybody know what hypoxia is? That's where they don't get enough oxygen to their brain, and essentially their brain cells die. Okay, so then not only do you have a spinal cord injury, but you got a traumatic brain injury too, which is about 50% of spinal cord injury. Did you know that? I just figured that out. I figured it was lower than that.
That was one thing that always stuck out to me with spinal cord injuries is the spinal cord in itself doesn't really affect any mental capacity. But it almost seems the majority of spinal cord injury patients I work with at that C level always had
Right.
some type of, something was just off.
Yeah.
For sure, like it was some
Right.
form of the TBI. And I didn't know that when I was here, and I looked it up and saw it.
Well, and I think that they focus more on the spinal cord injury because that's more life-threatening.
Right.
And then they forget all about the traumatic brain injury. But it's common. I just didn't realize it was as common as it is. And then also someone with a cervical level injury, they have issues with their respiratory. So usually they're going to go on a vent, but they will also have a surgery to place a tracheostomy, and that will help reduce the vent days. And if you've learned anything through this whole COVID mess, you don't want to be on a vent. And the least amount of time you can be on a ventilator, the better off you are. So they place that tracheostomy for that purpose. Also, they use external fixators or halos. And I mean, that's exactly what it is. It's a halo that goes around their head, and it's externally fixated into their skull, and it holds their head up, and it has a brace. So it will keep their body in perfect alignment, and it gives that spinal cord or those vertebrae and the rest of the injuries in the back, the bones, time to heal, because bones regenerate. And when they regenerate, you don't want to be all leaned over. You want to be perfect. TLSOs, thoracic lumbar sacrum orthotic, those are also common. Look on page 914. Just realized there was a picture. That is the halo and the vest. Yeah. So imagine doing ADLs with that thing on.
They're heavy.
Yeah.
Yeah.
Very good.
So what types of shirts would you want to use? Button up. And you always want to get bigger because something has to go over that vest. Yeah, and it doesn't really have to be button up. You can take some people's shirts, and I've seen this done. I'm not that crafty, or I could do it. I just don't want to. You can cut their shirt along the back and then Velcro, so they can still wear one of their regular shirts, like a blouse without buttons. Because I don't do button-up shirts. I just can't do button-ups. But you can take Velcro and put on the back. That way they can wear their regular shirt. You just want to make sure that it's big enough to go around the vest.
Do they shower with that vest?
No, they should avoid showers. And with the halo being as heavy as it is, it's kind of hard to maneuver around a shower and things, because it can get infected if like that gets wet, where that's fixated into the skull and all that. But you don't want to get it wet.
So they're doing like a sponge bath?
A sponge bath. They can sit on like the side of the tub or something like that if they want to use like a handheld shower to kind of spray the bottom part off. But yeah, the top part, and they're going to need assistance when they, to get that vest on and off. log rolling in the bed to get the vest off, and then someone, cleaning their back in that area, drying it off, and then log rolling them back onto the vest is really the only way to do it. Have you worked with a lot of spinal cord injury patients?
Yeah. Most, more paraplegics than what, but,
Mm-hmm.
but I think this pair is just more common. But yeah, I've had some high level.
Mine were always later, much later. in the
Yeah.
process. I never worked with.
That's
anybody who
what
was
I saw a lot.
Right on. We have a really cool field work rotation contract with the Science Center.
Oh, yeah.
It's in Virginia. It's one of the best spinal cord injury in the country, and it is hard rotation, but it's very
Well,
cool.
it's at CAMC, at Med Rehab, you will see, not in the ICU, but you will see spinal cord injured patients after they've stepped down and they've gotten out of ICU, they have an exoskeleton. That is the coolest
One of
thing.
the only ones in the state. I think Ruby might have one now. For a long time, they were the only one.
Yeah, one of my students, I think it was last year or year before last, they had a spinal cord injured patient and they put him in the exoskeleton because they had just gotten it. So they were practicing because he was the guinea pig. But it was the first time he was able to stand up inside that exoskeleton, and my student got to see it. So I think from that point on, they were hooked at CAMC. I can't remember who that was.
I don't remember. That was the finish, right?
But I think it was last year. I think it was Sam.
I think it was what?
Sam,
Maybe it
because
was.
she was there, and because I know she did a lot of full therapy.
It might have been. Yeah, that might have been.
Yeah, maybe.
CAMC has an amazing,
Oh, yeah.
one of the best.
So early intervention, from the minute that the patient comes in with a spinal cord injury, as soon as they are medically cleared, OT, PT, whoever needs to get in there, mainly OT and PT, go in from the very beginning, because early intervention with a spinal cord injury produces better outcomes. Okay. And there's research to back that up. I'm not just saying it because we're so good. I'm saying it because it's true. All right, so let's talk about emotions. The person who has the spinal cord injury, let's say, you're doing your thing, you get into a car accident, or you're riding. Who in here rides four-wheelers or ATVs? Okay, you're riding your ATV and you crash, and you have a spinal cord injury, traumatic spinal cord injury from, let's say, C4 down, complete. How is your life impacted? How is your family's life impacted? How is that going to impact your friends? Do you think your friends are going to stick around? Those are some of the emotions that your patients are going to be feeling. They're going to be experiencing that. So being empathetic to what they're going through is going to be crucial to them being rehabbed properly. Not sympathetic. They don't want your sympathy. They'll get sympathy from family and friends. They want empathy from you. They want you to be able to place yourself into their position and treat them the way you would want to be treated. That's what empathy is. Okay. So how, and also, do you think that the mechanism of the injury, the way that the person is injured, or the level of the spinal cord injury is going to make a difference in how this person's going to feel? You think age will play a significant role in how the person feels? Yeah.
Like a trauma, like, I don't know, a war injury or something, they're gonna be going through PTSD.
Yes. Yes. When I think when anybody, going back to the age thing, I think when anybody experiences something as traumatic as a spinal cord injury and I mean, this is a life-changing event, life-changing tragedy for everyone that's involved with this person. I think everybody has a problem dealing with it, but I can see the person, if you look at the different stages, if you look at the stages of development, is it Piaget stages of development? If the person is a teenager, which is the most common time, being a young man, because, you know, oh, well, I told them, and I'll tell you, young boys are dumb. My kids, my older boys are 34 and almost 30, and they were the dumbest teenagers God ever created. I mean, they did some stupid stuff, and I'm surprised that they're both still alive. Being a mom of boys is like not for the weak. You gotta have a strong stomach. But if you think about the typical age that boys get out, or even girls get out and, you know, ride four-wheelers and just do stupid stunts, to jump off of bridges to go swimming and jump off the dams at Summersville. How would that impact your life compared to someone like me who, I mean, even though I've got smaller kids, but I don't do anything, right? I've had my car 3 years. I've got 19,000 miles on it because I don't go anywhere. I go within like a 5-mile radius of my house. What's the difference? How's it going to impact my life compared to a younger teenager who is just full of everything? So yeah, I do think that age is going to play a significant role in how the person deals with that level of injury.
I have a interesting scenario. Can someone with a spinal cord injury become pregnant and give birth?
Like perform a natural labor?
Yeah.
If you know to push, it wouldn't have a C-section.
Well, I mean, when that baby's coming, whether you're pushing or not. You're just pushing it, just helping it along. But that baby's just kind of shoots out regardless.
I would definitely be for the thinking that you would have to have a C-section too.
When I was in OT school, I started, I did some caregiving work with a lady that she had, when she was 16, she dove into a shallow lake, broke her neck.
Mm-hmm.
But she got married. She and I became really, really good friends. She was able to get pregnant naturally and have a natural vaginal birth.
Mm-hmm.
I would just
It was just,
loss of sensation.
it was very hard on her body. It was very hard on her body. And she,
Well, and we're going to go over some medical complications that can bring up pregnancy and the excess weight gain and things like that. And I also have a good friend. He was 17 at the time. He was swimming, and he swam every day at the River Pool in Beckley. And every day, him and the lifeguard would race the length of the pool. Every day he dove in, and the lifeguard dove in, and they raced. One day, he dove in the shallow end like he always did, didn't come up. He dove in, and when he hit the bottom, his neck went forward, and he ended up with a C5. And he was going downhill quick, like he was going to end up dead. the things that he was doing. Spent months in rehab, getting, everything, all rehab and things like that. Now he's graduated with his master's degree from Marshall. He drives, he runs some big, huge security conglomerate somewhere, has more money than God. And, and his outlook on it is the spinal cord injury saved his life. But he has a positive experience from the outcome of the spinal cord injury. Not everybody's going to have that. But, he's thankful. He said he wished he could have done it without getting paralyzed. But if it wasn't for the spinal cord injury, he would be dead. But he still lives a full life. Drives, goes everywhere, goes to concerts. And, I tried to get him to as a guest speaker once. And it was at Mountain State. And when we were in the basement over there, there was no way he could get down to and it was very sad. And I was very upset. I was mad. It was like, well, can we not just take the students to another, anyway, that's another time. All right. So, hospitalizations. How do you think hospitalizations contribute to fatigue with the person that has a spinal cord injury? Right. And the person with a spinal cord injury, the reason that they end up back in the hospital is because of pressure sores. So 9 times out of 10, they're going to end up in the hospital. They have a pressure sore. They have to have a wound back. They're not going to be able to sleep. And everything that happens in these hospitals just contributes to their fatigue. When they are fatigued to a certain degree, they really never get back 100% of their energy. So a lot of the gains that they've made, it takes, what is it, 3 days to start losing, three days of just sedentary laying still to start losing muscle mass for a normal person, someone that doesn't have a spinal injury. Someone that's got a spinal cord injury, they've already got atrophied muscles, and all of that affects everything else, right? Just laying there affects everything. Your cardiovascular, just everything, your respiratory, your brain. So that's another reason that they contribute so much to their fatigue, to their added fatigue. So the effect, if a person also has a TBI, like I said, there's close to half of the people who have a spinal cord injury also have a traumatic brain injury. So once the person is medically cleared to work with, you do rehab with them for the spinal cord injury, but you also have to take into account their traumatic brain injury. Oftentimes it's a mild brain injury, but you just went over the brain injury chapter. So that's a dual diagnosis, and it's two big diagnoses that you're going to be working with. So you have to gear your education and the things that you do with your patient toward their brain injury. So that's one that you definitely want to say, hey, help me. Oh, yeah, it would take a lot of experience, a lot of clinical reason. Oh, I would definitely, yeah, I would be. Those range host level 4s, they can keep them. When it gets higher or it's lower than a 4, but those 4s, no. All right, so let's talk about spinal cord injury and pain. Would you be surprised to know that people that have a complete spinal cord injury also experience pain? Mm-mm. Phantom pain's when a limb's gone. Hmm. We'll talk about it. All right, so first let's talk about skin integrity. Why do you think pressure injuries and shear wounds, like shear, y'all know what a shear wound is? When someone with poor skin integrity like glides across a sheet or something like that, it can cause a skin tear. That's a shear wound. So why do you think that people with a spinal cord injury have such poor skin integrity? Sitting or laying all the time? How? Circulation, exactly. Their circulation is so poor that there's no oxygen, no blood, nothing getting to the skin. So they're going to be at a greater risk for skin breakdown, for pressure sores, and for skin tears. So when they are transferring from place to place, or when you're helping them move from one end of the bed to the other, you have to be very careful because of skin tear. And they can't feel it. So, if you don't pay attention to what's going on and they get a skin tear and it gets infected, then you got a whole nother set of problems. Besides SCI and TBI, you got possible sepsis setting in. So you have to really be careful with that person, okay? So some common sites for skin breakdown. Coccyx area. This area right here. They call this your sit bone. And this area kind of sticks out. This right here is a common area. Any of the bony prominences, the shoulder, most of the time though it is in the back. It is like the butt, but also the ankle, anything that has a bony prominence can be placed for skin breakdown.
Their pressure sores are the hardest to do.
Oh yeah, because circulation, poor circulation.
A lot of them come to skilled nursing for that. That's why they're there. They might be old spinal cord injuries. And that's
Right.
not why you're treating them. They go to the hospital, have a really, really bad wound. It just keeps getting worse. They send them to a skilled nursing facility for nursing care so they can constantly be changing up their wound dressing.
I had an older now talk about your dual diagnosis. I had an older spinal cord injured patient who also had the beginning stages of Alzheimer's and diabetes and a pressure sore. Very carefully. You don't, not on their coccyx. My grandmother had one. With a pressure sore, when it's got a little red dot, like when it's just red on the top of the surface, it's already started tunneling inside. Just the skin hasn't broken open yet. Okay, so that red dot, just that red skin, it's already a pressure wound. When we placed my grandmother sitting down, we put a donut underneath her, like one of those big donut cushions, to where there was nothing underneath the wound, but she was still able to sit. Now you can place someone like that, to make sure that there's nothing pushing up against the wound. But normally when I would do positioning with someone that had a pressure sore on their coccyx, we just move back and forth. Or they bandaged it real well, and if they were in a wheelchair, and we used the donut cushion for them. But you don't want to leave them in that position for very long. And my mom declared war on my grandmother's spinal cord, or her pressure wound, and got it from a 4 to where it was completely closed before she died.
Hard to do.
Oh man,
It's very hard.
I mean it was over a year.
Did she have it, you said on her to get far enough down where you can see it.
Oh, yeah. You can see everything. I mean, I could stick my fist in it. It started at Heartland and Beckley, and which we didn't blame them because, Grandma had Lewy body dementia and she was hateful as all get out and stubborn. And they would go into position her at night. They'd turn her on her side. She'd flop right back to her back every single time. And she's going to stay on her back. What can you do? Can't tire
That's
her.
the hardest one, those that take forever.
Oh, they do. It did take forever.
Like you said, when they tunnel, you start seeing the bones.
Oh, there was bones, there was tissue, we saw muscle. I mean, it was that far down.
The first thing I ever saw in person was with a wound nurse at the facility. She brought me in, and this woman, she's the one I told you guys about, that her wound was the shape of a bedpan. It's almost hospital left her on the bedpan.
Yes, I've seen that.
And it went all the way in. When you look at her wound, you saw her hip. That deep. And it was the worst. There's nothing.
Yeah, it's hard to describe what a wound smells like, but once you do smell it, you'll never forget it.
There's nothing that I smell worse. I mean, it's nothing. That was when I learned the trick of putting the Vicks vapor rub.
And, yeah.
Just wearing a surgical mask. That helps. If you still can smell it, it doesn't matter what you do, you still can, but that helps. I smelled it twice. It's rotten flesh. It's the person's literal flesh rotting. It's actually. In skilled nursing, you do see a lot of pressure disorders.
But we don't, as OTA practitioners, we don't deal directly with the wound. The nurses will deal directly with the wound, and then PTs and OTs, I think OTs can do wound care, right? As long as they have the training.
As long as it's established competency.
The PTs and OTs can do wound care, but OTAs cannot, and PTAs cannot.
Didn't they take it out of PT and OT's practice act then?
No.
One of the PTAs that used to work with his favorite thing, he should have been a nurse instead of a therapist.
I don't know. I'm gonna check on that because they shouldn't have if they did.
I'm kind of have a feeling that I know that he was all upset. He was all up in arms about it because he was not allowed to bill for it anymore.
Because you still
They
see,
took
I
it out.
mean, OTs are still doing, the wound care and outpatient all the time.
Maybe it's a facility.
Or it could be an assistant thing.
But it's good to experience, even if you're not doing the direct care. I encourage you guys when you're coworkers, if you have the opportunity to see it, it's important to see it. So
It is important to
understand
see.
what they're going through. I mean,
It
think about
helps
it.
you
got a
develop
hole
the
in your
ability
leg.
to provide
You got a hole in your
education,
leg.
and remember that this is a person.
Right.
This is your mom, this is your grandma, this is a person who's dealing with this, and it really helps. If you can have the experience, it will really help you with that empathy and being able to say, okay, how can we prevent this?
Prevention is the key. Prevention, positioning, proper positioning, paying attention to what you're doing, not leaving someone sitting on a bedpan for days. That's the key to preventing these wounds. But, I don't know about you guys, but when I get a paper cut, that hurts. Well, this is a paper cut times 1,000, right? Anytime you have an open wound on your body, it hurts. Think about one big enough to stick your fist in.
Touch.
And you can touch, yes, you can reach in and touch bone and cover the muscle and the tissue and yeah.
I did on that window study about it. I had gloves on and I touched the gun. And she was all about it. The nurse and the patient, they were all about, I was a fresh practitioner. I was in my first week of being a practitioner in that. What the hell did I get? She told me, she knew I was a fresh practitioner, and she said, hey, I want to show you something. So this is one of our worst pressure injuries. Told me the story, and she said, here, I want to show you this. And I really encourage you guys when you go to work when you're a fresh practitioner. If another practice says, here, I want to show you something, go. It's always something cool.
How do you think, what are some pieces of adaptive equipment that someone with a spinal cord injury can use to help prevent skin breakdown or to check their skin? The mirror is one, yes, absolutely. I always call it I call it the rear view mirror. I don't know, what's it called, skin inspection mirror? But I call it the rear view mirror because you can, see your rear from the mirror. So it's a rear view mirror. But that, and anything that's going to encourage positioning or movement. Some spinal cord injured patients, you may need to use a trapeze or something like that. Or, if they have any muscle function, we're going to go over that in a minute. They can do wheelchair push-ups to kind of relieve some of that pressure. Yes, they do that a lot. And then they have some that have sand in them that it has a vacuum and it's like constantly flowing sand to keep from the pressure from building up on their joints.
They do have that, and they're very expensive.
Very, very, and a lot of insurance will not pay for it.
But it would prevent future.
You're thinking that insurance companies are empathetic and that they have brains, and they don't.
Well, not
No.
the empathetic part. I mean, I think it would save money in wound care in the long term. Right?
It will.
So, like,
Absolutely would.
To prevent.
They'd rather take the chance.
They can pay $30,000 for this mattress one time that can help prevent this wound care, or they can pay $5,000 8 times, right? And it's cheaper in the short term to pay $5,000 for this wound care than it is for $30,000. That's the way insurance companies look at it, because it's all about. Because insurance is a corporation. Insurance companies are a corporation. They're there to make money. And that's when the empathy was taken out of healthcare, when insurance companies were allowed to make money. What? Don't get me started. That's that's a conversation that me and Cody could get into on Facebook and make people think we hate each other. Oh, if y'all saw our conversation the other night, y'all have been like, they're going to kill each other next time they see each other. We hadn't had a conversation like that in a while, though. Because usually I'm like, I'm going to slap the shit out of you next time. Yeah. I'm going to treat you like Chris Rock. He didn't just slap him. I mean, it was a pimp slap.
Chris Rock didn't budge. Well, he did, but barely.
Yeah, he was shocked. He was like, Will Smith just slapped the shit out of me. All right, so let's talk about some pain. There's 3 different types of pain that the spinal cord injured patient will deal with. There's mechanical, radicular, and central pain. Mechanical pain is a soft, it's pain within the soft tissue that's associated with that injury. And it's very common in the shoulders, okay? Radicular pain is like a shooting or a burning sensation that follows nerve distribution. And then central pain, that starts in the spinal cord, it kind of moves its way out. Those are the 3 types of pain that someone with a spinal cord injury deals with. Also spasms. Horrible, horrible muscles. Have y'all ever had a muscle spasm? Yes. Did you say no?
Every day.
So that, yes, exactly. And as a person with a spinal cord injury, they also experience really bad muscle spasms. it's sad to watch because I know how bad it hurts. Now, having a spinal cord injury also makes it difficult to regulate temperatures. And the patient will not sweat or shiver below the level of injury. Yeah. That's
why I feel weird about someone being
Well, I mean, they're going to be surrounded by a medical team. It's not like they're going to do at-home water birth. They're going to be there in the hospital with their legs in the stirrups, somebody guiding that baby out. But the baby's coming regardless.
throughout the pregnancy.
Somebody will have to be there to help. Somebody will have to be there. You know, there's
She was
just ways.
very well followed. Her husband is awesome and, a very high risk
Right?
pregnancy, so she was very well
I
followed.
feel like sitting all the time pregnant, like, is that what does it help affect the birth, like, or the growth of the baby? Like, do they need to do certain exercises all the time?
No. Smoking affects the birth, or affects the weight of the baby. What you eat. You know, in a perfect world, they want a pregnant woman up and moving around and exercising, but the baby's going to come regardless if you go up and exercise or not. I mean, it could have an effect, but. So some people that have tetraplegia, they don't sweat at all. They might sweat it like in their head, but not often, not always. That makes it difficult to regulate their own temperature. And when they can't feel anything, they don't sweat, what's to keep them from getting, having a heat stroke, right? So you have to teach the person with the spinal cord injury to pay attention to the outside weather, maybe limit their time outside, especially if it's really, really cold, to avoid hypothermia. Or if it's really, really hot, you want to make sure that they hydrate. And, you know, where they go in periodically because they are very sensitive to temperatures. And they will get hypothermic or hyperthermic quickly. All right, so let's discuss muscle tone. Normally for the first few weeks, day to the first few weeks, the person will have spinal shock, which means they will have no tone at all. Their spinal cord is just kind of, sitting there severing like, what the hell do I do now? And then once the shock is over, you'll start seeing an increase in tone. Normally, about 80% of patients will experience spasticity. And I know you all talked about spasticity and placidity, right? There are medications that can be given to help reduce the spasticity, but that comes with its own set of problems. When you're dealing with spasticity, there is no one thing is best. Okay, you just use a whole conglomerate of stuff, and it's going to require clinical reasoning skills. You could do orthotics. You can do casting, serial casting. Stretching of the muscles is good. E-stim is really good for that. Sorry. Using and managing spasticity for functional activities. It's possible to do that. How do you use and manage your spasticity for functional activities? Let's say that a person's experiencing their spasticity in the shoulder and the, common spasticity, and they're just kind of sitting there like this. how can this position be used?
Like propping yourself up, adding support.
Maybe, depending on the level of spinal cord injury, if they've got, they may have the ability to prop their elbows up. What about universal cuff? They can use a universal cuff, or they can do tenodesis grasp if they have spasticity in their fingers. And we're going to get into that here in just a minute. Let's see. You want to teach ergonomics with transfer training, and wheelchair propulsion techniques. Adaptive equipment and exercise is very important for preserving upper extremity functioning and stuff. I thought somebody was out there. I was like, where are you going? And stability. Also, you can teach the person to use a sliding board for transfer instead of their shoulders all the time. Because, if they're using their shoulders all the time for movement, for transfers, their shoulders tend to get tired. And the shoulder is very easily injured because it's, it's a big joint, but it's very susceptible to injury. So they can switch off and use the sliding board and the shoulders occasionally. You want to teach ergonomics again with wheelchair propulsion. So when they're you want to teach them to use their bigger muscles, their bigger joints for wheelchair propulsion, not their little joints. And again, this depends on the level of spinal cord injury that they have. Someone with like a C6, C7, they got some C4 down, has some upper body control, in coordinated control, but they still have some movement in the upper body. All right, then you've got the problem of neurogenic heterotopic ossification. Now, this is different than the heterotopic ossification from burns. Well, it's not really that different. It's just sort of different. The neurogenic heterotopic ossification, NHO, is experienced by the person that has the spinal cord injury. And it affects about 50% of the people that have a spinal cord injury. Normally, it will affect joints at or below the level of the injury, and it causes very limited range of motion. Usually, the bone will begin to form at about 1 month to several months post-injury. And have you whenever symptoms of a deep vein thrombosis? Sort of what that looks like, what that will feel like to the patient. The symptoms are similar to a deep vein thrombosis. Warm to the touch. It'll be red. The person just doesn't feel well. And, that's how you can kind of tell that it may be an NHO.
Bone forming where it's not supposed to be.
Mhm.
Okay.
So, proper range of motion or education for the family, the caregivers, for proper range of motion is going to be crucial to preventing this. Also, overly aggressive stretching can cause NHO to be there. I worked at a facility, I was doing PRN there, and they had these restorative aides who weren't supposed to be working with this man anyway, but it was way down in Richwood. So, they didn't nobody wanted to work down there because it was so far away. They would bring this man in, and he had probably had his spinal cord injury for about 20 years. Bring him in. They would stretch his hip to where his leg was back here by his ear. I mean, these aides had absolutely no knowledge of normal movements. So to be stretching this man the way that they were, I just kind of looked at him and I'm like, what do you, well, we do this all the time. Were you doing it wrong? You know, so I taught that, you know, and here I was PRN. I'm surprised they ever asked me to come back, but they did. So I taught them the proper way to stretch this guy. Because they were hurting him and he didn't realize it because he had a spinal cord injury. But I mean, he was, it was bad. His leg, I mean, it was both of them. One would have one leg and one would have the other leg and they'd stretch it way back here and he'd be sitting up here like, yeah, he was limber. That's some kind of pose. But yeah, it was, I was like, that's overstretching. That's why it's important to know the normal movements of a joint. Okay. Do what? Oh, it was, yeah. I mean, yeah. Imagine seeing it in person. I'm like, that's exactly what I said. I mean, it's like, yes, yes. I guess they were trying to get their work done sooner because they were like, I mean, and they weren't easy with the man. They took that man's legs and they stretched them way back here by his ear. And there was nothing he could do. I mean, he was paralyzed. So it was like, yeah. And he thought it was normal. He's like, because they had done it for so long. Standing frames. Standing frames are also very helpful to help prevent complications from prolonged sitting and to prevent pressure sores. So what this standing frame does is you put the person who has the spinal cord injury, it really, someone with a high level C is not appropriate. Someone with lower, like in the T's or even lower C's may be appropriate for it. To roll this person up into this standing frame, you help stand the person up and then you close the door behind them. So it's literally really holding them up in a way. But that's going to help them. That'll help relieve pressure. I mean, it helps them with osteoporosis. It helps them kind of regain some proprioception and knowledge of where they are in space. Good. The standing frames are great. I had a guy when I was at Institute at the State Rehab Center who had a pretty fresh spinal cord injury. He had, you know, some of the normal blood pressure drops and stuff like that. Well, we went to stand him up in the standing frame. He stood up, closed the door behind him, out he went. So he's like falling down inside this, and it was almost like he was melting down inside of that standing frame. And the guy was like 6'5". So me and this OT were like, oh my God, what are we gonna do? Yeah. So you got to be very careful.
The newer ones don't do the box ones anymore.
Mm-hmm.
What they do is a hydraulic system that has pads behind them. There's one behind their butt. There's locks behind their knees.
Oh, that's really cool.
It's a lot safer. And you crank them up. It's like a.
Oh, it would have to be, yeah.
Like a census band. You crank them up. They, you know, they have to have, you know, flexion and all that. Extremities that they hold on and they go little by little, and it stops them from throwing the box and shut the door, and then they pass down on you. Stops that because they get little by little.
Yeah. Well, and that's the thing with the older standing frame, the one that we used. You just had to stand them up. There was no, and this is why there's a problem. We're going to go over to that.
It takes a lot of help when you do those old boxes.
All right. So spinal cord injuries and blood pressures. How does spinal cord injuries affect blood pressures? People with a spinal cord injury will experience orthostatic hypotension. What is that? I know you've talked about it in other classes. Right, sudden drop in blood pressure. How do you fix that? And this happens to everybody, not just people with a spinal cord injury. Have you ever sat up too fast in bed when you get up in the morning? What do? You just lay back down, right? You do, that's the same exact thing you do with the person who has a spinal cord injury. And then you want to slowly elevate them back into sitting up, okay? Then you have autonomic dysreflexia. Now, this is a medical emergency. This is when their blood pressure goes too high. And it's usually as a result of something restricting their blood flow. It could be a distended bladder. It could be their bowel. It could be, a lot of times they'll wear these compression binders around their abdomen to keep, from developing deep vein thrombosis, things like that. It could be a blockage in their catheter. Just anything can cause, and it's anything that's above a 20 milligram raise in their blood pressure. But when you're in that situation, and I've had this situation happen to me before at the rehab center, you don't think about taking the blood pressure and say, okay, is it more than 20 than it normally is? It happens, right? And it's a medical emergency. So the first thing that you're going to do, and normally it's an issue for anybody with a T6 or above. Okay. Pain can also cause a sudden increase in blood pressure. The first thing that you're going to do is call for medical assistance. Okay. Even if you're in a hospital, you're still going to call for medical assistance. The second thing is remove the issue, whatever the issue is. If they have a compression binder around their abdomen, take it off. Okay. Check their catheter. If they have an indwelling catheter, check their catheter to make sure that it's not stopped up. If you can find the issue, remove it. And then setting the patient up and laying them down, and then setting them up and laying them down, you're eliciting not heterotopic auscultation, you're eliciting orthostatic hypotension, which can then in turn bring that blood pressure down. So up and down, up and down. Some of the symptoms of autonomic dysreflexia, and I swear I had a patient or a student tell me that she had this, she did not have. You cannot have autonomic dysreflexia if you do not have a spinal cord injury. It's not physically possible. But I had a student who swore up and down she had it. I said, no, you don't. Oh, but I do. She had diarrhea. And some of the symptoms may have been the same. But she had headaches, bradycardia, goosebumps, flushing, which is turning red, and then sweating above the level of injury are also symptoms of autonomic dysreflexia. Okay. If you don't have a spinal cord injury, T6 or above, you don't have it. So that's not one of those things that you can self-diagnose. All right, also deep vein thrombosis. There's also some complications that you're going to see. Normally, they're formed in the lower extremity, around the abdomen or the pelvis. You have to be extremely careful with these. The patient's not going to know if they have a DVT or not. They're not going to feel it. But if it turns into an embolism, which is a traveling blood clot, it could travel to the heart, to the lungs, to the head. Then you've got another problem. They're either going to die or they're going to have a heart attack or a stroke. Some anticoagulants, coagulants are given, and then they can also do what they call an IVC filter. It's a filter that they put in the back of the inferior vena cava that can help filter out the blood and keep it from clotting. All right, then we've got some gastrointestinal functions. We love talking about this stuff. Bowel and bladder. So people with a spinal cord injury can have a neurogenic bladder. And what that means is their brain and the bladder no longer communicate. So the brain is not telling the bladder when it's full. So they're not peeing. Well, that's going to cause urinary tract infections. I mean, can cause lots of stuff. So the patient may need either to do self-cath or indwelling catheters. Self-caths is when they do a catheter on themselves about every 4 to 6 hours, just to make sure that they're getting the urine out. I have a grandson who has spina bifida, and he has to be self-cathed every 4 to 6 hours. And you teach the person to do that themselves. And, that is part of the OTA role, is to teach them. You will have nursing helping. I mean, nurses will help teach that because, we just don't concentrate on that. That's a specialty that we don't concentrate on in school. But if they do have to do self-cath, then yes, you will be responsible for helping with that. The OTA will be doing the bowel and bladder management program, trying to get them on a schedule to manage bowel and bladder. Or they can also do an indwelling catheter, which is, and that's usually for the ones who aren't capable of doing a self-cath, that have the higher level Cs than the ones with the lower level. So the indwelling catheter is one that, you have to teach the person, if they can, to empty it themselves, or have them teach the person, their caregiver, how to empty it. But you don't do anything with the indwelling catheter other than empty it. Neurogenic bowel is also another common problem with someone that has a spinal cord injury. And it's also a key. The key to better bladder control is routine. Okay, so the neurogenic bladder or the neurogenic bowel, the brain does not tell the bowel that it needs to empty. So what happens if you don't poop? You get backed up, and then you can get septic, and you can die. So you want to make sure that you do a routine bowel management program as well.
Since there's no action down there, does it just come out?
Mm-hmm.
Okay. Do they get a bag then?
No, normally no. They want to avoid getting the bag if at all possible. Normally they don't do a colostomy bag unless they are missing, unless they've had to have a colonectomy, like their colon removed because of cancer or something like that. So no, they won't get a bag. They'll just wear a brief. Well, and also the complete spinal cord injury, the ones that have problems with their bowel, they're usually more self-conscious. They don't want to go out in public because of that reason. So you can maybe, work with them, work with the dietitian, and say, okay, this is the things that causes them to experience stomach issues, gastro issues. So let's remove this from their diet, replace it with something else, and then have them do a bowel management program every few hours. That way they can avoid that issue. And maybe plan their days out between the times they have to go to the bathroom. And there's also like bedside toilets and things like that. There's things that they can do that can help, but that's where it's important to do the bowel management program. There are times that they will get impacted and they will need assistance in digging out that impaction. That's when you're going to teach them how to do it themselves, if at all possible. Okay, if you look at page 925, figure 35.7. That is anal stimulation for the bowel program. They do it while they're laying on their side, and that encourages bowel movement. This would be for incomplete. Complete's usually just going to come out. Now there may be times that they will get impacted, and someone will have to dig it up for them. But that's just part of it. Okay. And then there's also a bowel stimulator. If they have a hard time reaching with their finger and doing digital stimulation, then they can use this tool for that.
Somebody in the knowledge that was in for a really long time. They had something in there that was like made it all come out. Is that not something they
There are, they do, I have seen fecal bags placed with people with wounds. Have you seen the fecal bag?
I have seen the fecal bags.
The rectal fecal bag, not the colostomy bag.
I don't know. I don't know why they.
I think that as a last resort, they might. But if you can help them manage their bowel by putting them on a routine schedule, they're better off.
They take a laxative.
I guess. I mean.
Yeah, they're more likely to be constipated than have diarrhea
Mhm.
because of lack of movement.
Mhm.
So things are just kind of sitting in the gut. And so they're more likely to be constipated. So a lot of your patients will take like fiber supplements and laxatives to kind of help get things moving. But usually like the fiber supplements, like the Metamucil kind of stuff, that you just mix into a drink.
Yeah, that stuff is not
helps to
bad
keep-
with
helps to
Gatorade.
keep things regulated.
You have to, when you get 45, nobody in here is even close. When you get 45, everything starts going downhill, and you've got to start getting all these different tests done. That was horrible. Luckily, I have no memory of the actual procedure. It's just the prep for the procedure was horrible. I still have it. Do what? I was asleep. I would have blocked it out, but I was asleep. Yeah, they were wheeling me into whatever room they were taking me. I don't even know where they were taking me. She gave me something in my IV, and all of a sudden I reached over and she said, "Yeah, you're feeling a burn, and that's going to numb." That's all I remember. It was like, and then the next thing I knew, I woke up. The nurse said, "You're all good. You're clean up there." Thank you. I knew that. All right, so spinal cord injuries and reproduction. There can be a lot of different issues that will affect reproduction or sexual activity with a spinal cord injury. Bowel and bladder incontinence is one big one that I can think of. Urinary tract infections are another. Pain and spasticity are also confounding factors that can contribute to issues with sexual activity. There are some men that can obtain an erection and then some can't. It just really depends. And then some females can get pregnant after a spinal cord injury and some can't. But when you're dealing with someone that has a spinal cord injury, you should also address sexual activity as you would any other ADL, because sexual activity is an ADL. Okay. Now, yeah, of course, you're going to use your clinical reasoning skills. If it's a person below 18, under the age of 18, no, you don't want to bring up sex. They may bring it up with you, and you can discuss it in general medical terms. But sexual activity is something that, if you think about the age of the person who typically does experience a spinal cord injury, that's something that's really important to them. CAMC has videos on the different positions and things like that. It's not porn videos. It's sexual activity when you have a spinal cord injury. Or it's like educational videos. I guess you can get porn videos. I don't know. I've never.
There's a whole like Vice episode in Canada, like he started a service for like spinal cord injury and stuff. Like they massage and sexual. Yeah, it's really interesting.
There's a video, I actually have seen that, I think it was the, did an interview with a couple of that's not, they paid a company to come in and assist them in movements and.
Yeah, I mean, and that's something that, you know, you've got to be mature enough to address. Within your licensing, we are not sex educators. We provide information and education about different positions and things like that that can eliminate additional complications. But, you know, we don't tell a person how to do it, because that's not what we do. That's not our job. Okay, so now we're going to get into the individual levels. Okay, I want you to look at page 930. We're almost out of time. This is such a long chapter, and it's such a lot of information. You really need 2 days. When you're looking at this chapter, or at this chart, look at the C1 through C4. And if you look at the movements gained, or the movements or spared, they have some head and neck control, but more at the C3 and C4. Okay. C4 will be able to do a shoulder shrug. All right. So they'll have a shoulder shrug. So that means they may have the levator scapula, right? They may have use of that muscle. And they may have some diaphragm control, but they can't cough. So these people are going to need cough assisters. And also they're going to, and there's a lot, I put a lot of video. Did you get the videos that I put on my eLearn? There's like tons of videos on mine. Okay. But I want you to watch those videos. We don't have time today, but those videos will really kind of bring a lot of this into understanding what it looks like.
6 videos.
Yeah. Yeah, there should be. Yeah. Those are really good videos that kind of go through dressing at a C4 and I mean, just all kinds of stuff. So what we're going to focus on when we're working with the patient is what they can do, not what they can't do. What muscles do they have? What movements do they have? And how can we use that for interventions? Okay, and it's always going to be client-based. If the patient is not interested in learning how to wash dishes, because that's not what they do, you're not going to focus on that. Okay, you want to focus on what they want to do. Now the person with the C2 through C4, and this says C1. A C1, if a person has a C1, they're gonna be dead. So really it goes from a C2 down to a C4. Okay. They're gonna be paralyzed from the neck down. How many people know who Christopher Reeves is? Superman. Look him up if you don't know who he is. He was the original Superman. Well, I guess he would. He was the Superman as we know Superman. He was like the sexiest human being on the face of the planet. Suffered a spinal cord injury from being on a horse, doing a horse jump. And yeah, I think he had a C3, didn't he? C2, C3?
It was pretty high because he was on a vent.
Yeah, he was on a vent, and he had to have a power wheelchair, and he had like the blow straw that could, huh?
Sip and puff.
Sip and puff, yeah, that maneuvered his wheelchair and things like that. Look him up if you don't know who he is. He had a C2. Yeah. No, it probably was because it was a high. Because I remember someone saying he was one level off from being dead. So if it was a C1, he would have been dead. So yeah, he probably did. That was a C2. I still love to watch his movie.
Was he the Superman that flew around the world to make him go backwards?
Yes.
To save the love of his life, Lois Lane.
Yeah, it don't make sense.
Oh, it makes perfect sense. He turned back time, you see. He was Superman. He could do that.
Chris and Dana Reed Foundation, when he was paralyzed, the outpouring of support, and then his wealth and fame was able to generate so much money, that they started this foundation, and then the research that we can contribute to him is just unbelievable.
Oh yeah, because just who he is. I mean, he's dead now, but. So what do you think is going to be your focus as OT practitioners? How are you going to focus your treatment interventions for the C2 through the C4 spinal cord injured patient?
Why does the book say C1?
Just because it's wrong.
Okay.
Because if it's C1, you don't have to worry about it. They're dead.
It's your range of motion and safety. Or like the passive range of motion.
Passive range of motion. Positioning. Absolutely. Caregiver education. What else? Getting in and out of the home. Home modifications, ramps. How are they going to get back and forth anywhere? So maybe they might need modified van, things like that. Another really important thing that you're going to do is educate the patient on how to advocate for their own care. That's a hard thing to do, is instruct someone on how to provide care for you. So that's going to be really important. Okay. All right. Now at C2 through C4, they're said to have tetraplegia. Okay, so regardless if it's a complete or an incomplete lesion or an injury, they're going to have tetraplegia. There's going to be some involvement in all four limbs and the trunk. Okay. All right, so then you've got the level C5. They're also considered to have tetraplegia. So if you look at the movements gained and the movements spared, they have their head, neck, shoulder, They have some bicep brachii for elbow flexion. They could do some supination. Now the C4 from the C or C5 from C1 to C and C4 to the C5 is like huge. It's like it's just a huge difference in what they can do from a C4 to a C5. You wouldn't think that one level would make that much difference, but it does. So if you look on page the bottom of 930 to 931, this gives you some of the education that you're going to have to provide. This tells you all about the preparatory methods and the tasks and some of the functional goals and things like that that you're going to work on. The C levels are the most important to learn. Know those like the back of your hand. I guarantee you on the big exam, there will be some questions about this. And it won't say at the C5 level, the person can do this, this, and this. It will say, this would be the best activity for the person who has a C5 complete spinal cord injury. And it will give you, your 4 choices. Or this might be a 6-choice multi-select. So the C levels are really important to know. The video that I was going to show you earlier was the one I posted on, I think I posted it in this group, Facebook a long time ago. It was the spinal cord injury song. Memorize that song. I'll post it again. Okay. Yeah, just memorize that song. It's a mnemonic and it's great. They have one for traumatic brain injury too. The one I found though, it just didn't get me. It was like too slow. I like the fast. That one I just couldn't.
I think there's one on past the OT as well.
There might be, yeah. Maybe, but that TBI one, the one that was real slow, there's another fast one that I'll see if I can find. That slow one, it was like, oh my God, this is the most boring thing ever. I couldn't memorize that if someone paid me. All right, so that's how you're going to look at all this. Now, when you get to the C6, this is a really important level. At the C6 level, they're going to start gaining a lot more independence. It's another jump, huge jump from C5 to C6. But they'll have the ability to use wrist flexors and wrist extensors. So that means that they're going to be able to use a tenodesis grasp. Have you all went over the tenodesis yet? Good. Okay. So at that C6, when you are doing range of motion with these patients, do not range their hands into their fingers into extension. Okay. You want to make sure that their fingers stay flexed. Why? Right, so they can use that grip. If you range their fingers into extension, they can't use their tenodesis grasp anymore. They
slap splints on their hands.
Huh?
Or slap splints.
Yeah, don't slap splints on their hands either, because the whole purpose for using the tenodesis grasp is to be able to flex. Because when you flex, what happens to your, just naturally, put your hand up here like this. Flex your hand. What do your fingers do? They extend. Okay. When you extend your wrist, what do your fingers do naturally? They flex, right? So to use that tenodesis grasp, and with a spinal cord injury patient, you're talking about a lot tighter than what you all experience it. But when they go down into flexion of their wrist, they can grasp whatever it is that they're wanting to hold, or they can grab a hold of it. Then they're taught to extend their wrist, and that is going to flex their fingers so they can have a grip on it. And then they reverse it to be able to release. Normally, it's like this. And they may have like a little bit of a opening there, but instead of it being in like this, usually their fingers, their hands will look like that. So that when they go down, their hand just normally extends the fingers, but they still have a little bit of spasticity going on. So then they can learn to cup it and bring their hand back up, wrist into extension, and that will help them grasp it. A lot of them have a pretty tight grasp. Oh yeah, when the ones who've been using that Tenodesis grasp for so long, yeah, they put something in there, you ain't never getting it out. Now also at the C6, the client should be able to roll in the bed. They should be able to move their arms across midline with a little bit of force. So, you know, and a lot of times what they'll do is they'll kind of swing their body around and that'll swing their arm. And just watch the videos. They will also have some tricep, a little bit of tricep. So they could do maybe some overhead, a little bit of overhead activity, reaching items from a shelf, manual propelling of a wheelchair at the C6. And then you got the C7. Again, C7 is a huge jump from a C6 to a C7. They have a lot more stuff that they can do at the C7. If you look at page 936, that starts at the C7. So they have the wrist flexors and the triceps plus all the other stuff that they had from the C2 on down. Okay, so you're just adding an additional layer of, or an additional muscle movement, an additional movement into that with the C7. So, I mean, if they have wrist flexors and the flexion in the C6, it's just kind of gravity just kind of propels that down. Wrist extension is what they needed for, but with the C7, they have purposeful wrist flexion. Okay, and so it's a little bit different than just pushing it, like it just falling down. So they have purposeful wrist flexion, they have their triceps. So, you know, wheelchair push-ups, anytime that they have, that you see that they have a little bit of stability in their shoulders, you might want to start with some shoulder shrugs to kind of get that the shoulders built up. Because, you know, if any natural return does occur, if they do, because sometimes that happens after the swelling goes down and things like that, you know, the spine might be in shock for 6 months. And when that spine goes out of shock, they may have this, and the swelling goes down, they may have some return of function at a different level. So you don't want them to lose what they have in case they do have that return of function. Okay. All right, then you've got C8 and T1. Now, when I'm talking about spinal cord, your nerves, you have 8 cervical nerves, but only 7 cervical vertebrae. Okay, there's 2 nerves that come from the C7 and the T1. Okay, so there's 2 spinal nerves here between these 2 vertebrae. Yeah, these 2 vertebrae. Okay, that's your C8 and your T1. So that may be a test question on this test in here. I don't know, but just know there's 7 cervical vertebrae, 8 cervical nerves. Okay. C8 and T1, this is when you're going to start seeing a lot more upper body control. They're going to have a lot more control over their upper body. They're going to have, I mean, it might be less coordinated than what it normally would be, but who cares? They've got some control. A little bit of control, maybe a little bit of trunk control. And then as each level, as it goes down, then the trunk control and the back, their back and everything else, they get more control with each level as it goes down. So C8 to T1. So everything from C2 to T1 is what you really need to concentrate on. T2 to T12, I mean, it's kind of is what it is. It's like with each level, they gain more control. They have some upper body stuff. They gain more control over their trunk. And to the point where someone with a T10 may still be able to ambulate certain, not coordinated, but, you know, a certain distance. Maybe put a little bit of, you know, using like furniture or something like that, transferring over. All right, it goes all the way down to the L1 and below. The reason they label it like that's because you put the L1, and it usually there's really not a lot of disability that goes along with the L's, with the lower lumbar spinal cord. Let's see. So the C's. From T2 to S5 is considered paraplegia. C8 and T1 is still in that tetraplegia range, so you've still got some involvement in all four. But when you get from the T2 to the S5 is considered paraplegia. All right. Gosh, we're out of time. Can you finish this? I left off on page 20. Is there any questions?
When you said big exam.
NBCOT exam. The big one.
The Mac Daddy exam.
Yeah, the Mac Daddy of all the exams.
So on here,